Welcome to Healthbeat, your monthly check on South Africa's healthcare system. I'm Mia Malan. For over 20 years, South Africa has built the world's biggest HIV treatment program, backed by millions of US dollars through the President's Emergency Plan for AIDS Relief, or PEPFAR. But now, US funding cuts are making it harder for South Africa's 8 million people with HIV to get their treatment. The same goes for those who take a daily pill to prevent infection. The funding cuts threaten to undo decades of progress.
It's the significant numbers of people who find it difficult to attend clinics, who do default, who don't want to get tested, but who are at high risk. It's that end that we've suddenly lost. And if we don't think about how we can get that back on track, we're going to see the numbers of people being infected increase, the numbers of people who are sick increasing quite quickly.
Today on Healthbeat, we ask, when the money runs out, how do you keep people on treatment and stop the virus from spreading? At Euro in Parktown, Johannesburg, researchers are crunching the numbers. How much does HIV cost us, and how much will it take to win the fight? For Lisa Jamieson and Gesine Meyer-Roth, it's life and death stuff. Lisa, tell us how your work helps us to understand what's happening in the broader health system.
At Hero, we do a lot of health economics work. We cost studies, so we go out into the field, we cost what it actually costs per person to do different things, so different HIV interventions. So whether it's treating someone with ARVs or whether it's HIV testing or even pre-exposure prophylaxis. So we have a cost per person for a variety of different HIV interventions. But what we also have, and this is thanks to Lee Johnson at UCT, we've got the Tembisa model, a mathematical model of the HIV epidemic in South Africa. And it simulates a real world setting for us to understand how many people have HIV, and we can project this forward into the future. And we can also, with this model, scale up HIV interventions to estimate what impact they would have over the longer term.
So the data that you guys collect feed directly into the Tembisa model, and that's the model that the health department uses to plan for HIV programs, right?
Exactly. It's also the model that UNAIDS use to estimate where we are with the HIV epidemic. So it's very widely used and it's very well calibrated to existing data in South Africa.
Gesine, how did being a doctor help you to do this work?
I started as a junior doctor in Berlin, where I'm from, working in pediatrics. And even then, whatever we could do as clinicians was guided and restricted by economics. And I remember that angering me to a point that I wanted to know what the methodology is, who says, and who gets to set these methods that then result in someone being told to discharge a 2-year-old on day 3. I decided to change careers, become a health economist, did a PhD, came to South Africa to collect data for a cost-effectiveness analysis of the local AIT program.
And you then turn that information into something that the government can use to figure out, can they afford a certain intervention?
We can help inform the government exactly what is the best way forward, for the next 20 years. Where should they rather put their money? Where should they focus on in terms of the HIV epidemic, which is the most cost-effective option going forward? We also look at stuff like injectable PrEP, for example, and new interventions, and at what cost should these come at for it to be cost-effective and affordable as well for the South African government.
What did your HIV investment case recommend the health departments focus on?
The most cost-effective intervention is to further scale up condom use. In this country, we are already giving out between 500 and 1 billion condoms every year. We believe that one of the better interventions to do is to offer better condoms that are actually more pleasant to use, because condoms don't fit in every relationship. We do know that there need to be additional options available. The other intervention that's always come to the top is actually more treatment. We've seen over the years that AIT in itself, HIV treatment in itself, is one of the most cost-effective interventions, also because it has a huge effect on prevention. People who take treatment successfully cannot transmit HIV to other people.
PEPFAR the AIDS fund of the US government, so much of that investment was on the ground workers to go find the people who fall off treatment. And now we don't have that money any longer. And you've done one of your modeling studies finding that if we don't replace any of that lost money, we're going to see a 38% increase in AIDS deaths in the next 4 years. What does that mean for the economy?
We are all blessed enough to not have ever seen the full impact of full-blown, unmitigated AIDS in any country in the world. And that is because governments around the world came together 20 years ago, 15 years ago, and started rolling out treatment to those in need. There's good reasons to believe that if we left the gap produced by the US government pulling HIV funding in South Africa unfunded, we would see that in the economy as well.
The average age of someone with HIV in this country is 41. You know, this middle age, the economically active. We will see people who are working, contributing to the economy, who can no longer access their treatment in convenient ways that they used to before. And that could very well have disastrous impacts on their lives.
We have added 10 years to the average life expectancy of South Africans because of the successful treatment rollout. We were very, very close to basically ending AIDS as a public health threat, and we are very much risking to lose all of that. And we've started to see the data as well that suggests that people are finding it harder to access treatment. There are whole districts where HIV testing is hard to access, and especially population groups who find it hard to access treatment at a normal primary healthcare clinic are underserved and are very much falling out of care at a rapid rate.
We have about 130,000 new infections a year. And in addition to that, we're looking at between 150,000 and 295,000 extra infections over the next 4 years. What does that mean for our health system?
This will essentially result in us needing to put an additional between 11 billion and 26 billion rand additional money into the HIV program just for the next 4 years alone, just to be able to cover the impact of the PEPFAR defunding.
We have 7.2 million people living with HIV in South Africa, and we need them to stay on treatment. But it's not so much about finding them, it's really about making it easier for them to stay in care. We do believe that most people out of those 7.2 million have been on treatment at some stage. We just didn't make it easy enough for them to stay there.
Gesine Meyer-Roth and Lisa Jamieson, thanks very much for your time today. Coming up, what does our HIV future look like without US funding? Welcome back to HealthBeat. What does our HIV future look like without US funding? Here to tell us is Health Minister Aaron Motsoaledi. Dr. Motsoaledi, when you were the Health Minister the first time around, you did a fantastic thing. You built the largest HIV treatment program in the world, and you worked with HIV activists to make this happen. But now we're at a point where they're angry with you, and they say you are denying the impact of the funding crisis that we're facing because of the US government's funding cuts. Do you think they're being unfair?
Well, Mia, it depends what you mean by activist. HIV is activist. For your information, I'm still working with them, even up to today, because you are aware that we wanted to increase the number of people who are on ARVs.
So they say that you're being defensive about the impact of the funding cuts. And if I must name names, you know, I was in a webinar the other day, Linda Gale Becker from UCT wants to help. There's Francois Venter from Wits University who's criticizing. There's Glenda Gray, the former head of the South African Medical Research Council, who's criticizing. And all these people were the people who helped to get us through COVID. They were on a ministerial committee. So from you, I want to know, wouldn't it make sense to get all these people, like during COVID, on a regular basis in a room and meet with them and see where's the biggest bang for our buck?
Yeah, no, why not? We don't, look, what we gain by fighting, in fact, I've said, It will be a very sad day, Mia, for Trump to come and take money away and South Africa start boxing each other. I even said so when I was presenting to Parliament. Even before Parliament, in the press conference, I read that, I said, we need to come together like we did before. We can't be creating enemies of each other because some of the enemies are really imaginary.
Earlier, we asked Professor Helen Rees, head of the Wits Reproductive Health Institute, who lost millions in funding, if a ministerial advisory committee would help.
We had a Ministerial Advisory Committee for drugs and we had a Ministerial Advisory Committee for vaccines at that stage. So I agree, what we could think about is what would be useful urgently now to do some short-term remedies so that we do not lose tens of thousands of people to follow up. That could be the starting point.
So I hear you that you say that there's different government departments that will come together, right? Yes. Would you consider a ministerial committee like we had in COVID?
So there's nothing wrong in establishing a ministerial advisory committee like that. It always helps. It always helps. All I'm denying, and I'm still denying it, is that some say the HIV/AIDS program has collapsed. Others say it's on the verge of collapsing because we did nothing. In other words, they say there was no action and no activity. I presented date by date. Who did we speak to, when? I outlined how many clinics were run by PEPFAR, which are closed, and how many patients were helped there, and how did we get the files of those patients, where have we sent them. The only thing that we failed to do, which was we are still failing and we are not the only ones, is to put money on the table. I'm still waiting for Treasury, but there's no way. They will just take over and fund everything. Even the funders we have met, I've met lots of funders who are funding health, Bill and Melinda Gates Foundation, the Wellcome Trust. I've met the French Development Agency. All of them are saying we would like to help, but they made it clear that nobody is going to be able to replace what Trump has taken back. That one, they made it very clear. But they said they'll find a way in which they can help. And up to today, apart from Global Fund itself, which said, please buy ARVs worth 1 billion. That's the only funding that came in since February when the cuts were mentioned.
In a press conference in early May, you said that the Health Department had not applied for emergency funding from the Treasury through the Public Finances Management Act. But I interviewed your head of the NHI, Nicholas Crisp, when he compiled a report with PEPFAR data to see how much money you would need to replace funds if you also work in savings. And he mentioned that the Health Department was considering applying. Have you applied or not?
I was querying the word emergency. It emerged in Parliament, by the way, from the activists, that we did not apply for emergency funding. And I said, how? I wasn't aware that there is emergency funding in Treasury because we had so many emergencies in health. I phoned the DG, Dr. Peterson, I asked him about this emergency funding. He tried to explain how it works, and I couldn't understand. I phoned the minister, and I said, is there something called emergency funding in health? They said, no, but you know, in terms of PFMA, if you are short of this, you can spend money. Then I said, please explain, is there emergency funding? It did not come up very clear. And we chose to apply for this one via PFMA. Whether you call it an emergency or not, that's why I was saying Parliament must call Treasury to put them in front of them to explain very clearly, because people are saying in the Act it says emergency funding. So the issue here was not whether we applied or not. The issue was how do you define the money we've applied for? That was the main issue.
Okay, so do I understand you correctly? You have applied through the Public Finance Management Act, Section 16, for money. It's just about what you call that money. It should not be called emergency funds.
Yes, in my mind, emergency funding is you apply now, they give it to you immediately because it's an emergency. And that's where the differences were. But that we've applied to Treasury, we started as early as February.
And for how much money did you apply?
No. I wouldn't like to disclose that because we are still discussing with Treasury. Really, it will be very unfair because we are still going to discuss with them and find out and all that. Because if I put a figure here and Treasury goes to something else, it will also raise other questions. So please allow me not to disclose that. because we put scenarios. We didn't just say, give us this much. We said, if you are able to do this scenario, this is this, this is that, this is that. But certainly what I can disclose is that nobody, including Treasury, have actually said, as for everything that Trump has taken away and will be able to replace it, nobody is able to do that up to now.
Coming up, will the Health Department pay for the 6-monthly HIV prevention jab? You're watching Healthbeat, and we're looking at ways to keep up the fight against HIV with limited funding. Important tools like these mobile clinics were funded by PEPFAR. How will the Health Department carry on with the work they did, visiting and monitoring patients? With me is Health Minister Aaron Motsoaledi. When it comes to health workers who lost their jobs, would your way forward be to re-establish the NGOs, or would it rather be to take those workers and make them part of the Health Department?
There's no promise at the present moment that so many people lost their jobs will absorb them, because as I'm saying, within health itself, before Trump took his job, we had a lineup of people who don't have jobs, and it was in the papers. Doctors who have completed community service, nurses who never got jobs, other healthcare professionals who never did. So all those things need to be resolved, and we are looking forward to this money that Treasury has given us to see what we can do with that. If Treasury, in giving us money, say we are giving you this much money to fund those people who lost their jobs, of course we'll do so.
So if Treasury or a donor says, yes, money for those people who lost their jobs, what I'm trying to understand is, what would be the easiest way forward?
Of course, if they say we are giving you money to employ these people, we can't refuse, because donors' money is always conditional. We will have no option but to do it. For instance, there are people who are working on our CCMDD program, which has got 3 million people in it. CCMD, the Central Chronic Medication Dispensing and Distribution Program. There are people who are working there who are paid by PEPFAR. And if that program collapses, we'll be in trouble. So we said those ones will start making sure that even within the Department of Health itself, we'll get money to keep them, because otherwise the medication program will be in serious trouble.
Now, one of the things that can help with preventing new infections is, of course, HIV prevention medication. And we already have a daily pill, but there's now also injectable forms of it that you don't have to take as often. And one of those forms are called lenacapavir, which is the injection that you take every 6 months. There are also studies that show that if we give it to many people, between 2 and 4 million people a year in South Africa for the next 8 years, we can end AIDS as a public health threat by 2032.
I'm delighted to show these results of Purpose 1. A total of 55 incident HIV infections were observed during almost 5,000 person years of follow-up. 0 occurred in the lenacapavir group.
It was a breakthrough moment, met with a standing ovation at last year's World AIDS Conference. For the past 3 years, lenacapavir has been used to treat people for whom standard HIV medication doesn't work. But last year, studies showed that the medicine also stops HIV-negative people from getting the virus. Not a single woman in over 2,000 trial participants who got jabbed twice a year contracted the virus. Linda Becker from South Africa led the study. At Yero, researchers have worked out how many people in South Africa would need to take the jab at least once over the next 8 years to end AIDS by 2032.
Lenacapavir is what I would deem a game changer for HIV prevention. Imagine being able to take an injection every 6 months. It prevents you from getting HIV infected. But in our study, what we assumed to achieve this kind of impact was We need about 2 to 4 million people to get that injection at least once in this country, right? And if we can do that, then we could, what we call end the HIV epidemic 10 years sooner than what we would have if we didn't have it.
The question now is, for how much will lenacapavir's maker, Gilead Sciences, sell the drug to countries like South Africa? Generics will only come onto the market in 2027. Hero's researchers have done the sums. If a year's treatment costs over $225, so just over 4,000 rands, it won't be worth South Africa's while.
If we can put between 2 and 4 million people on lenacapavir, this is just getting at least one injection, then we can prevent between 27 and 35% of new HIV infections over the next 20 years.
Earlier in June, the US Food and Drug Administration became the first regulator in the world to register lenacapavir as HIV prevention medicine. The European Medicines Agency's approval will now likely follow. South Africa's medicines regulator, SAHPRA, expects lenacapavir to be approved in the country by early 2026. Is the health department looking at ways to be able to buy this lenacapavir? I know it's not registered yet. I'm talking, next year when it's registered.
PEPFAR have agreed to fund lenacapavir. And of course, they withdrawn with all their fundings. When it arrives, if there's no funder who is interested and it has been registered, we look within our own budget and see exactly how many young people can we put on lenacapavir, because we believe it's a game changer. There is no way that we can leave that to go by. We'll try everything in our power, but the question is, if it comes at the cost with which it's happening overseas, it's just beyond our reach. It's beyond the reach of Africa. And what is being debated now internationally is how do they make it within reach of us in the African continent.
If we think about this whole Trump cutting up funds, what are the lessons that you've learned, or the world you think has learned, about accepting international donations?
It's a wake-up call for the whole world to depend on only one country. It has shown to be very dangerous, and from now onwards, our plan must be, how do we stand up on our own, such that if somebody comes to help, it's just in addition to what we already have.
Dr. Oren Motsoaledi, thanks very much for your time today, and thanks for visiting us at the studio.
Thank you very much.
That's our June edition of HealthBeat. Follow us online and send us your ideas at health@bekesisa.org.